our session horses and zebras, distinguishing between PTSD and psychosis in children and adolescents. We have our session speaker, Dr. Ross Young here, and she will be facilitating the session in just a moment. I do want to remind you, if you have seen this session before and received credit for it, you will not be able to receive credit again. I am leaving the screen up as some folks are having a bit of challenge getting into Cloud CME. And there is a comment on here, if it's the first time you're texting in your attendance or such, there are some things that you need to do. So I, again, am welcoming you this afternoon now, and I will have this turned over to Dr. Ross Young. I just want to double check that she is on here real quick.
I am here.
Okay, great.
Excellent. Is now a good time for me to go ahead and
share
go my
ahead
screen?
And share your screen. I just have stopped sharing.
Fabulous. Okay, let me share that. Okay, nope, I don't want presenter view. Is everyone able to see this okay?
We are actually seeing it. Let's see if we can put it into the other view.
Yeah, when I go to full screen, it is.
And I can share the screen, I can share the slides if you need me to.
Okay, that may work better. Let me see, because the other option is sharing just in Teams.
All right, let me pull that up.
I apologize. I don't know why it is not allowing me to share. While we're getting this pulled up, thanks everyone for coming today and for attending. Before we get started, while Laura is pulling up the slides for us, I'm Haley Ross Young. I'm Associate Professor here in the Department of Psychiatry and Behavioral Medicine at UT Health. I am a psychologist by trade, and I do not have any financial disclosures to report today. Our learning objectives for today, I want folks to just, first of all, be able to kind of identify and recognize the DSM diagnostic criteria for PTSD and for schizophrenia in children and teens. To identify the prevalence rates of both of these diagnoses in terms of PTSD and childhood-onset schizophrenia. And to discuss appropriate screening practices for both of these diagnoses in medical settings. I'm going to be reasonable about what you can do in the settings that you're in. And so thinking about how we can screen for both of these, as well as discussing some evidence-based interventions for appropriate referrals that you may be able to make. CPAN is also a great resource to help you do that, and Laura will talk a bit more about that at the end of this presentation as well. And there are also some brief skills that you may be able to use in the context that you are in. So I included the title for this presentation is inspired by this quote. When you hear hoofbeats, look for horses, not zebras. This is credited to an unknown source. Do folks have ideas about what this quote is getting at? You can drop it in the chat, or you can shout it out if you'd like. And I do like presentations to be interactive, so I apologize in advance. I'll be asking you to look for something common, stay with the most common. Excellent. Excellent. So yeah, if anyone has seen the show House or something like that, there can be this temptation to look for the most exotic explanation that perhaps we see. Often though, things that are the most common for a reason. And so if we're seeing certain things, we might not want to jump to the most kind of rare conclusion. So let's kind of compare diagnostically. When we're thinking about post-traumatic stress disorder, we have certain criteria that folks need to meet in order to qualify for a diagnosis. This includes, first of all, a criterion A event, or exposure to actual or threatened death or violence of some kind. So someone needs to have experienced it, witnessed it, learned about an event like this happening. That could include something like a natural disaster, a physical or sexual assault of some kind, a traumatic death, right? Any of this abuse that folks might have experienced or witnessed. And associated with this are one or more symptoms of what we would consider intrusion. So memories or experiences of that event intruding on the present through things like nightmares or flashbacks as certain examples. Symptoms of avoidance. So people avoiding internal experiences or reminders. Could be thoughts, feelings, or memories associated with the trauma, but they may also avoid external things. So for example, if you get in a car accident, you might avoid driving on the street where you were in your accident, or you may get to the point where you actually avoid driving altogether or even getting into a car, right? So you could avoid a lot of different types of things. You may avoid watching movies that have car accidents in them, for example. We would also look for the presence of 2 or more alterations in mood. So this is not an exhaustive list, but it could include things like irritability, hypervigilance, sleep disturbance, negative alterations in the way that we think about ourselves or other people or the world. So seeing ourselves as bad or dirty or weak, seeing others as always out to get us or dangerous, or the world as a very unsafe place. 2 or more symptoms of hyperarousal. That includes that irritability, the hypervigilance, the sleep disturbance, that head on a swivel experience. These need to last for more than 1 month. And there needs to be clinically significant distress or impairment present and not be attributable to another cause. We may also find dissociative symptoms that are present. So folks may dissociate or kind of zone out if they are under extreme stress or they're experiencing a lot of these trauma symptoms. And the reason that we don't want to rush to this diagnosis is because many folks who experience a traumatic event may have some of these experiences kind of in those first days or weeks after a trauma, but go through a process of more natural recovery, whereas some folks get stuck in recovery. So that's why we have this kind of 1 month period that we need to see symptoms persisting for before we diagnose someone with PTSD. Now, if we're looking in kids under 6 years old, which some of you may be pediatricians or do a lot of work with people who are early childhood or kind of early development, there are some changes in these criteria. So we would expect to see, right, that criterion A event, exposure to an actual or threatened death or violence again. We need 1 or more intrusive symptoms, but children under 6 years may not be able to describe these as distressing. They may not be able to describe them as, for example, flashbacks, or even if they're having nightmares, they may not be able to really clearly describe the content of the nightmares, and the content may not appear to be directly related to that criterion A event. Additionally, we're looking for 1 or more avoidance or mood alteration symptoms, so that the threshold is a little lower if we're looking in folks who are under 6. Again, we're going to have that external avoidance criteria, so that's avoiding people, places, or things. In young children, we might notice an increased frequency of negative emotional states in terms of being more sad or more tearful, or more like angry or aggressive. We may find a lack of positive emotions. They lose interest in things that they previously enjoyed, not interested in hobbies, don't get as much, don't demonstrate as much positive behavior in terms of like happiness and contentment. They may also be socially withdrawn, so kind of being less connected to caregivers, friends, family, other folks like that. And then I already mentioned that lack of interest. And then we can also see 2 or more hyperarousal symptoms. So those things like irritability, and then that hypervigilance. But in kids 6 and under, we remove that reckless or self-destructive behavior criterion that we are looking at in ages 6 and up. So overall, domains are largely the same for symptoms that we're looking for. The presentation may be a little bit different. and the number of criteria that children under 6 need to meet is lower than for folks over 6. And then we'll look at schizophrenia. So in schizophrenia, there's not an age range here that we're going to be looking at. However, what we need to see is 2 or more of the following symptoms for at least 1 month, and at least one of those symptoms needs to be one of the 3 items that I have bolded here. So we need to see either hallucinations, delusions, or disorganized speech, in addition to at least one of those other 5. So hallucinations would be sensory experiences in the absence of external stimuli. So when people think of hallucinations, they often think of hearing voices, or they might think of seeing things. It could also be smelling things that other folks don't smell, tasting things that might taste rotten, or like decaying flesh, or taste really like bad in some way that other folks don't taste if they were to try the same thing. And it could also be tactile, right? We could feel things that are in absence of an external stimuli. Those delusions are really fixed beliefs that are very strongly held despite evidence to the contrary. So they could be things along themes of like paranoia, religiosity, thinking you have special powers, different things like of that nature. And when we're looking at disorganized speech or behavior, that's really this encompasses a lot of different presentations that you might see, but you might find folks have a really difficult time like staying on topic if there's disorganized speech. They start talking about one thing, they quickly change topic, and it's completely irrelevant to what you're talking about. Or they're making associations based on the sounds of words rather than the content of words. Or they're just using a lot of words in a jumble rather than meaningful sentences. Same thing with disorganized behavior or catatonia. This encompasses a lot of different behaviors that you might see, but it could include things like the weather's pretty cold right now in Tyler, Texas. If you see someone outside in a bathing suit instead of their winter coat, that could be considered disorganized behavior, right? They're engaging in a behavior that doesn't make sense given the context of what's currently happening. And then catatonia can also look a couple different ways. You think about that waxy kind of rigidity where folks don't move of their own volition, but they might be moved into position by an external person. Or if they're really catatonic, they might just lay in bed, not move, not speak. In extreme cases, folks don't eat, don't drink, all of those things. And then negative symptoms actually account for the greatest impairment in schizophrenia, but they tend to be what people think of the least. And those are things like just decreased speech, that flat affect, right? There's not a lot of facial expression, decreased motivation to like start activities or engage in things, that social withdrawal, all of those things, they're called negative because they represent like the lack of something. This is also associated with clinically significant impairment in functioning in a variety of domains. And we need to see at least some of these signs persisting for at least 6 months, with at least 1 month of those active symptoms. So often the pattern, although not always, is those negative symptoms kind of persist during residual phases, with folks sometimes having more of these, what we call positive symptoms, the hallucinations or the delusions, during active symptom flare-ups. We want to rule out that these are not caused by another substance or a medical condition or another diagnosis that may be present. So that's kind of the difference between, yes, and I see, Kimmy, your question, can it be the perception of pain that is not present? Yes, it certainly can. That could be a tactile, potentially a tactile hallucination. Great question. So I kind of alluded to this already, this distinction between what we consider positive and negative symptoms. That's not to say that some are pleasant and some are unpleasant, but rather hallucinations and delusions we kind of think of as an excess of normative experience. Like we have too much of a good thing and we start having experiences with no external stimuli. Negative symptoms are called that because it's that absence of a normative experience. So it's the reduction in things that we would see in terms of that emotional expression, social activation, all of those things. A great description that a former supervisor gave to me is, in depression, It's almost like the battery on a toy that's like running out. People get really slowed, and sometimes you can see that like psychomotor slowing. When we're thinking about negative symptoms, it's almost like the battery has just been completely taken out of the toy, right? There's just that removal of those experiences almost entirely. And that's kind of what we're looking at. So when we are thinking about diagnostically, especially if we're thinking about childhood onset schizophrenia, which we'll talk about kind of occurring ages 12 and under, what aspects of normative development do you think we should consider before assigning a diagnosis of childhood onset schizophrenia? What else could younger kids have going on? You can drop it in the chat or you can speak up. Imagination.
I was going to say magical thinking.
Yep, there's definitely some magical thinking, imaginary friends, excellent. Yep, so Kenya, you're skipping ahead. I love it. So other disorders that could be ruled out, things like social anxiety or learning disorders, definitely things that we would want to consider. Awesome. Yep, fears. So kids may be fearful of things like the dark in your example. Excellent. It may not sound super realistic or rational to us as adults. That's not how their brains are really working yet. Great thoughts. Any other thoughts? Well, Kenya, you led us into autism. Yep, lack of sleep. Excellent. So we're leading into the second question, which is fabulous. What other disorders should be ruled out prior to assigning a diagnosis? So we've got the social anxiety, learning disorder, autism, adjustment disorders. Excellent. Major depression, post-traumatic stress disorder. Yes, y'all are spot on. And you're also identifying a lot of things that occur, yep, MDD with psychosis, that occur much more frequently than childhood onset schizophrenia. Our presentation today, however, is going to be focused on differentiating more between PTSD and childhood onset schizophrenia specifically. So based on some of those characteristics of PTSD that I talked about, which of those diagnostic criteria do you think might be the most likely to be interpreted as psychotic symptoms by folks? Re-experiencing, yes, fabulous. The social withdrawal, fabulous. Y'all are all earning gold stars today. Flashbacks, yes, excellent. Yep, so things like flashbacks or re-experiencing can sometimes almost be experienced as hallucinations, right, in quality. Social withdrawal, excellent. Any other ideas that come to mind? If folks have dissociation, sometimes dissociation can look a bit like a psychotic symptom. Fabulous. All right, so let's see. Next slide, please. Abuse and response, yep. Excellent. How'd it go? So this is why we want to talk about prevalence and base rates when we're talking about differentiating between schizophrenia and PTSD. So if you look at the lifetime prevalence of schizophrenia, we can see that it is between 0.3 and 0.7% of people. The highest estimates are up to 1%, and that's including people across the lifespan, so that's including adults. And the peak age of onset tends to be that late teens to kind of mid-20s range of time. Prior to adolescence, onset is even more rare. We actually don't have great numbers on it, but it's even below that kind of 0.3 to 0.7 range. And what we want to make sure we do is hit on the things y'all already did such a great job identifying, right? What is a positive symptom versus normative fantasy play? What is disorganized speech or behavior in a schizophrenia spectrum disorder versus maybe behaviors or speech that we're seeing in other more common childhood onset disorders like autism spectrum disorder or ADHD. And we also want to consider the impact of culture on all of the patients that we're working with. So, if if the patient is not making eye contact with you, that might not be a sign of social withdrawal. That could be completely culturally normative, and we want to think about that. PTSD, on the other hand, the lifetime prevalence is estimated to be much higher, and is considered likely underreported. So 8.7% is where it's estimated, but it's likely actually higher than that. Historically, it has been lower in younger children, but some of the hypotheses around that are we just haven't really been able to like assess it very well in younger kids, and we've had poor screening and practices with relation to that. PTSD is also really comorbid with younger children with things like oppositional defiant disorder and separation anxiety. And kids who have trauma exposure early in their lives are at risk for developing other behavioral and emotional symptoms and problems down the line. So even if someone goes on to later develop schizophrenia, we want to make sure that we're really screening for trauma in early childhood because we want to try to mitigate as much of that risk as we can. Next slide, please. So what are the possible relationships between trauma and psychosis? There are a couple, because it would be too easy if there were just one. So the first is, which is backed up by quite a bit of literature, right? Folks who have a history of trauma actually might go on to then develop psychosis. Certainly not everyone, but trauma can be a risk factor for later development of a schizophrenia spectrum disorder. And we know that pretty high percentages of adults with a schizophrenia spectrum disorder also meet criteria for PTSD at present. Psychosis in and of itself, the experience of psychosis and some of the things that happen when someone is psychotic, like involuntary hospitalizations, seclusion and restraint, perhaps being taken to juvenile justice or to jail, the experience of that can actually lead to trauma in and of itself. So the experience of being psychotic, of being treated in the medical setting can kind of lead to trauma symptoms. And then that relationship can also be considered to be bidirectional, right? So maybe we have some trauma from early childhood. It's a risk factor triggered by a genetic predisposition. We go on to develop psychosis. Then we have some really traumatizing impacts of being psychotic, being untreated, that leads to more trauma. And so now they're kind of in a mutually reinforcing relationship. Does that make sense to folks? Fabulous. All right, next slide. So what are some common factors? We can see high arousal and hypervigilance in both PTSD and psychosis, right? Especially if we're thinking about folks who are experiencing paranoia. Their head is also always on a swivel. And one thing that we want to kind of check in on is that fear or that paranoia reality-based, right? Is someone actually being stalked because that happens? Or is this something that is not reality-based for that person? We also see sleep disturbances, which someone mentioned in the chat earlier, in both disorders. We can see avoidance and emotional numbing in both disorders, this kind of selective attention and engagement in safety behaviors, like repeated checking of things, checking locks, for instance, or things of that nature. Some dysfunctional thought control strategies we can see in both, especially in adults and younger children. But things like, well, if I just do this, then nothing bad will happen to me. Or if I just do what the voice tells me, then the voice won't hurt me, right? We can see some of these unhelpful thought control strategies. Higher levels of expressed emotion can cause relapse for both, which means people in the individual's life, whether they're a child, an adolescent, or an adult, if every time this person gets upset, right, if they feel anxious, if they feel angry or frustrated, they go, did you take your medicine? Are you getting sick again? Oh, what's wrong with you? That actually creates a lot of stress for the individual and can lead to more symptom relapse. We can see dissociation in both disorders, and then those intrusive phenomena you all were describing. So intrusive thoughts, sensory experiences, as well as like emotions. So there's some common factors that kind of underlie both of these experiences that make it a little bit tricky to disentangle them, especially in a brief kind of medical context. And so if we can go to the next slide, please. Fabulous, thank you. So as I kind of mentioned earlier, and we'll go through this briefly, but the estimates are like 75 to 98% of people who have a disabling psychiatric condition also have experienced multiple traumatic events. So it is worthwhile to really think about, and we'll talk later in this presentation about increasing trauma screening and thinking about how we're doing our trauma screenings in the settings that we're in. Trauma exposures we talked about as a childhood risk factor for later development of psychosis. And in a US sample of adults who experienced childhood physical or sexual abuse, 2 or more of those events led to a significantly increased risk of developing psychosis down the line. As you can see, the UK sample, their particular childhood traumas differed a bit in what was predictive. For those of you who are practicing in the US, I'm going to assume it's everyone here. We want to think about the prevalence of folks you work with, whether they're children, teens, or adults who have experienced childhood physical or sexual abuse, kind of thinking about that as a big risk factor. And that these exposures to trauma can also impact risk of suicide, right? So making sure we're doing safety screening and that we're doing safety planning appropriately, earlier onset of psychiatric symptoms, and also they're associated with more severe or significant symptoms and decreased treatment effectiveness, especially if we're conceptualizing from this trauma perspective. If all we're treating is the hallucination or the delusion, and we're not treating that underlying trauma, we might expect treatment to be less effective. And then we also talked about how some trauma symptoms can look like psychotic symptoms, and y'all certainly identified some great ones with like flashbacks, dissociation, avoidance, all of that. And then we also want to consider the role of systemic and or institutionalized oppression and trauma. Again, when folks are coming in and endorsing certain symptoms or experiences, we don't want to automatically assume that this is not reality-based. We want to make sure we're doing our due diligence to think about, okay, are these things that have been happening? Has this person experienced like repeated traumas or abuses from multiple people in their lives or multiple systems that they've engaged with that could have led to the development of a PTSD diagnosis? So what to do when they're what happens when they're both present? Well, we know there's an increased risk of suicidal ideation and suicide attempts, regardless of like the age of the patient. We see like increased emotional ability and poor social functioning among folks. Fewer folks actually achieve symptom remission and tend to have poor treatment compliance or adherence. We also see higher levels of that comorbid substance use, which also can worsen symptoms. We see more dissociative symptoms and higher levels of mood and anxiety. And interestingly, childhood sexual abuse has actually been specifically linked to hallucinations and delusions later in life for folks. So we want to be thinking about those experiences as well and making sure we're assessing for them. Next slide. Fabulous. So for folks who are here, I want to be mindful of our time, but when you're thinking about your practice in the setting that you're in, is it more common for you to see folks, kids or teens who are coming in with trauma histories and possible PTSD? Or is it more common for you to see folks who are coming in with potentially a childhood onset or early onset schizophrenia diagnosis? I see mostly trauma history and PTSD in the chat. Okay. See more trauma. Yeah, folks see a lot of trauma. Okay, so that kind of fits with our expectation of prevalence and base rates, right? Is that we're seeing more folks coming in with things like trauma, substance use. Excellent. So what is your current practice for screening for trauma or psychosis with your child and adolescent patients that you may see? Screen for ACEs. Excellent. Checking in about domestic abuse. Fabulous. Anything else? Okay, fabulous. Well, we'll talk about some other things that you may be able to incorporate to kind of like observation without parent or guardian present. Excellent. Excellent idea. Fabulous. And then I kind of touched on how we want to think about culture when we're working with folks, but especially when it comes to things like A full psych eval, yes, certainly. We can consider referring for that. That would be excellent. And Laura, yes, I appreciate that. CPAN has access to some of these screening tools. So I think Laura will speak more to that at the end of our presentation. We certainly want to think about these cultural factors in terms of, like, if someone's coming in and they're talking about their religious beliefs, right? Whether or not that's something we agree with, or we hold the same beliefs, what we really want to know is this normative for that person's family, their culture, their religion? If so, and it's not distressing and it's not causing problems, might not be something that is in fact symptomatic. We'll skip on to the next one because I want to spend some time on. So screening measures. So as someone noted, and I apologize, it's just your phone number visible, so I'm not sure your name. A full psychological evaluation is really like the most comprehensive way and the most thorough way to get a clear diagnostic answer. However, not all patients have access to that. There are certainly wait lists and things of that nature. So in the meantime, screening is something that you can do in your clinic, with the caveat, screeners are not diagnostic. So if you screen someone and they screen at an elevated risk, that means we need to do a little bit more digging. It doesn't mean we're going to assign a diagnosis at that point in time. So I've listed here some different options for screeners. Some of these are actually free to use. Some of them there is a fee for. But for children, I have a list here of things like the Child PTSD Symptom Scale, the Child Stress Disorders Checklist, the Child Trauma Screening Questionnaire, things like that you can kind of build into your clinic protocols or your flows, your workflows, to kind of periodically administer to children. If you're looking at adolescents, so that kind of like 13 to 18 range, things like the UCLA PTSD reaction index can be really helpful. Again, the trauma symptom checklist. And then you have things like the Children's Psychiatric Rating Scale or the Brief Psychiatric Rating Scale that you can use with your adolescent patients. You can also, if they screen positive or if you have questions about this, you can ask more questions in your interview, your interaction with the patient, about specific labeled behaviors. So instead of saying things like, has anyone ever sexually abused you? Especially depending on the age, some kids might not know what that means, or they might not realize that what they experienced is sexual abuse. So sometimes asking more targeted questions like, has anyone ever touched you without your permission? Or has anyone ever touched you, especially with like smaller children, in your bathing suit area without your permission? Has anyone ever like hit you or kicked you? When we're asking like really specific questions like that, it may get folks thinking about, oh, yes, that happened, without asking them to put the label of like abuse on something that they experienced. We can also ask about how their family, or if it's appropriate, their religion or their culture interprets some of these experiences that they've been having. Do they think that there's a medical cause? Or do they think that something else is going on? If so, what is their description? What do they think would be helpful? That can be really important, especially if as the provider, you're going to have a conversation potentially about a medication or therapy. It can be really helpful to figure out how open is this family, what questions or concerns do they have, and what resources can we provide them to kind of address some of these questions or concerns. And then again, we want to think about, are these beliefs or experiences abnormal in the child's cultural context? So we do certainly find in certain like racial or ethnic groups and in certain age groups, especially if someone has lost a loved one recently, it might not be uncommon that they report hearing or seeing that loved one after they've died, without that being a psychotic experience. And that's really conceptualized as more, this is part of a normative grief reaction for this person's culture. And if you ask, like, is this something other people experience? They're saying, yes, it is. My mom saw them too, or this happens. This happens for multiple people in my family. We might not be as concerned about it. Then if someone is saying, no, this isn't culturally normative and my family's worried about me that might be when we need to ask a few more questions. So kind of thinking about how can we not only ask some of these specific questions, things also, if we're thinking about psychosis, like, do you ever hear voices talking to you? What do they sound like? Where are they coming from? Do you recognize the voices or not? Asking those specific questions rather than just saying like, are you having hallucinations or do you hear voices? Sometimes people hear noises. So do you hear noises that you can't explain or that other people don't hear? And really thinking about how you can specifically label these experiences in your screening questions. Fabulous. So then what can you do in terms of treatment? And I love seeing that someone already said full psychological evaluation. That's definitely something that we can refer for. If you screen, right, and you have concerns or someone does get an evaluation, you can also refer for treatment. And this is a great opportunity to like collaborate with CPAN as well. When we're thinking about evidence-based treatment for children, so kind of that 12 and under range, if we're looking at a PTSD or a trauma-related disorder, SSRIs are kind of what we have currently as best practice for pharmacological treatment. We don't have a ton of evidence at this point in the literature to support psychopharmacological intervention in general for PTSD in kids. Outpatient therapy like TFCBT or trauma-focused cognitive behavioral therapy is considered like the gold standard treatment. And so that can be something that you can work with families, you can work with CPAN to try to connect your child patient to a provider who provides TFCBT. And then there's also some evidence for psychosocial interventions like EMDR and psychoeducation. If we're looking at childhood onset psychosis, that referral to psychiatry and psychology for further assessment and treatment is really important because it's difficult to do the medication management, certainly in like a more primary care setting or pediatric setting. If we're looking at evidence-based psychotherapy, things like CBT or like family-focused therapies or parent management training have kind of the most evidence when we're looking at childhood onset schizophrenia. And then again, we have a little less info about long-term effects of psychopharmacological intervention, but usually second generation antipsychotics are kind of what is primarily prescribed to children with childhood onset psychosis. If we're looking at adolescents, this list will look very similar when we're thinking about trauma. Again, it's the SSRIs if we're looking at medication. And then depending on the age of the adolescent, we could either look at TFCBT or CPT, cognitive processing therapy, in terms of best practice for psychotherapy intervention. The cutoff there is usually around like age 16 or 18, depending on the maturity and cognitive ability of the child. If we're looking at adolescent onset psychosis, again, some of these second gen antipsychotics that I've listed here are things that have the most evidence currently in the literature for use. And then as well, CBT for psychosis and family-focused therapies. And then because this is occurring during the like educational period, really getting these teens and their families connected with like supported education and employment can really help prevent a schizophrenia spectrum disorder from like derailing their educational experience or their occupational kind of future. And so we want to think about, 504 plans or things like that to really help support the child or the adolescent in the learning environment, and thinking about like, how can we also connect them to meaningful and achievable work and study to keep them active, involved, engaged, rather than withdrawn. Case management services are also fantastic for assisting with connection to these resources. And then working on things like stress management can be really helpful as well. There are also some really brief cross-cutting skills. I included them here. I believe Laura also has handouts. I think I sent these last year. And if not, I'm happy to resend them so that they can be distributed to attendees or folks who are interested in receiving them. But there are even some very brief skills that you can do kind of in a 15 or 30-minute session with a kid, teen, and their parents, whether they're experiencing trauma or psychosis that could be helpful in that moment. And the first one is something called sensory grounding, which I've listed here. It asks the person to really keep their eyes open, be present in the room that they're in, and name 5 things they can see, 4 things they can feel or touch, right? 3 things they can hear, 2 things they can smell, and 1 thing that they can taste. And the reason we want to emphasize we're keeping our eyes open is because if they're experiencing those intrusions of trauma or they're experiencing dissociation, keeping your eyes open and engaging with like the world around you helps bring you back to the present. Same thing if they're experiencing like hallucinations or delusions, this can also kind of help keep them grounded in the present. You can use the skill this way, or if they like just looking around and naming things, then you can just stick to the top skill and name as many things as you can see. So there are a lot of ways to kind of adapt this for your practice as well. Other skills that you can use include things like this basic deep breathing or abdominal breathing. The one thing that I really recommend to folks is it needs to be from the diaphragm. So sometimes folks say they do deep breathing, but it's their chest that's moving. And this is a great opportunity to kind of do like breath retraining. And if you're working with kids or teens who have a background in playing an instrument or singing, really like encouraging them to like use that diaphragm to take deep breaths. For kids, you can include fun things like pretending that you're blowing up a balloon in your stomach, right? And include fun imagery, or things of that. You can make up any example that you'd like, but get them to practice some deep breathing with you for the relaxation benefit. Fabulous. And then we can skip ahead. Look, point name, this is just a visual grounding skill. I do want to be mindful of our time. So this is just also looking around and doing only visual grounding. This is a skill that you can use. So our key takeaways for today that I really want folks to walk away with is screening for trauma exposure and symptoms, and even psychosis should be done routinely. So depending on the clinic or the setting that you're in, think about like what workflow or what policies do we currently have set up for consistent screening? If none, how can we establish some of these things? How can we build this into our flow just so that we're checking in on it? And then if the screening is negative for both, we don't have to go further and ask more questions. But how are we making sure we're doing our due diligence to do this screening? I included some questions here that are just, again, examples of those behavioral things you can ask, like, does your mind play tricks on you? What happens when you misbehave? Do your parents have fights, and how do they fight, or what do their fights look like or sound like? Can be information. If someone said they screen for domestic abuse, can I see you screen for domestic abuse? And so these could be other questions that we're asking as well. While also remembering screenings aren't standalone diagnostic tools. So they give us more information that we need to follow up on. Once we've done a screening, right, if someone screens positive, we then do have a responsibility to do something with that information. So what do we do at that point in time? Well, we can ask some more questions about like developmental and cultural normativity before we jump to conclusions. If we have a 4-year-old who's describing an imaginary friend, and they've had this friend for a while, great. We want to make sure that we're screening for any suicidal or homicidal ideation or self-harm, even in children and adolescents. I think sometimes folks think it doesn't occur in this age group, and it does. So we want to make sure that we're doing that screening, and that if we get that information, we're safety planning appropriately. We're helping parents or guardians or whomever keep the home environment safe. That we're screening for substance use, including things that are legal, like alcohol and tobacco or nicotine use. All of those substances are associated with psychiatric comorbidities as well. And so we just want to kind of keep an eye on that, and work with teens and kids to reduce or eliminate the use of those substances if possible. Again, refer to that qualified mental health professional for a more comprehensive evaluation. And especially the kid or teen hasn't had it before, we want to get a comprehensive medical workup, especially if there's no or very limited family history. This seems to be coming out of nowhere. We want to make sure that we're doing our due diligence and that, blood work, like everything is within the normal range. If there's any associated like headaches or kind of concerns in terms of functioning, that would indicate we might want to be looking for like temporal lobe epilepsy or something like that, that we're doing the appropriate screenings to rule those things out before we're jumping to psychiatric conclusions. And then we want to just always remember, we don't want to just wait for things to get worse, right? So if we pick up on something in our screening, we want to stay on top of that because early intervention is always best. So the earlier that we can get involved, the earlier that we can try to treat and kind of get ahead of these symptoms and prevent things from worsening, the better for patients and for families. And so thinking about, that watchful waiting, what can we do during this time period to help promote the child's health and functioning and the family's health and functioning? And that can be referral to therapy, or case management, or I saw some discussion in the chat as well about like those 504 plans or things of that nature to help support the kid in the environment so that they're not being, bullied or struggling academically and then feeling worse about themselves. The next slide. I also strongly encourage, everyone is here today, so fantastic, you're already doing this, but engage in professional development and consultation with other providers with expertise in this area. So if you're stumped or if this is not your area and you're like, I need to know more, or I want to run this by someone, CPAN is a fantastic resource to reach out to and say like, I have this patient in my clinic and I've got some questions, like what do you recommend? Or if you have a colleague in your clinic or in your network that you can reach out to, I strongly suggest doing those things. I also always recommend as providers, we engage in our own self-reflection and self-management. I've worked with professionals who are kind of hesitant or worried to ask about things like trauma or suicide or psychosis because they're sometimes afraid to offend people or they're afraid of what the answer might be, or they just feel kind of anxious because it's an awkward topic. And that's that makes sense. That's normal. And we can't let our nervousness kind of hold us back from doing appropriate screenings and treatment for our patients. So really thinking about how can I be aware of what's going on for me? How can I manage that appropriately so that I'm doing what I need to do with folks without making them even more anxious, right? Without communicating my anxiety to patients. And again, we don't want to just look for confirmatory evidence. We want to think about the whole clinical picture. Again, this is where consultation and CPAN can really come in handy because you can kind of present everything and say, all right, I think it might be this, but what am I missing? And I think while thinking about that, approaching every clinical interaction from a trauma-informed lens, whether we know there's trauma present or not. We do know that patients don't always disclose, and certainly they don't always disclose right away. And so thinking about in our settings, how can we be as trauma-informed, as respectful of patients as possible? If we're going to touch a patient, tell them what's going to happen and where we're going to touch them before we do it. Ask them permission for things, give them a choice about where they sit in the exam room. We just want to be very thoughtful about how we're interacting with folks so that we're not contributing to potentially more negative experiences with like the medical community. And even if folks haven't experienced a prior trauma, these are often things they still appreciate. And so just by being kind of trauma informed more generally, we can improve experiences for folks. And if we'll go to the last slide. Thank you. We have some great resources here. I hope these are helpful to folks. The National Child Traumatic Stress Network has a great website in terms of like educational information for providers, for families, information about evidence-based treatments and screening tools. I already mentioned CPAN. I want to make sure I give Laura some time at the end to discuss the services a little bit more in depth. The National Suicide Prevention Lifeline has a website. Their number is also 988, and you can give that to your patients. And then there are some great free support groups like NAMI. And NAMI actually has a chapter here in Tyler, and those support groups are free. And then for your teens who like their phone apps, things like My Mental Health Crisis Plan or the Virtual Hope Box can also be great things to discuss with your patients. And then I have attached 2 videos here. If folks want to watch those more in depth, they're examples of doing a child interview and a parent interview where you're doing a quick screen for trauma, kind of more conversationally in interview form. So if folks think that would be really helpful to watch, you'll have access to the copies of the slide, and you can kind of pull those up on YouTube and see what you think about them. And then if we'll go to the next slide, these are the references that I pulled. I know we're towards the end of time and we want to leave time for some questions and for Laura to discuss CPAN a bit. So thank you all for your time and attention. Are there any questions or comments that I can answer for folks today?
Would love to take questions here today. Opening this up, please just unmute yourself and ask your questions if you have one. I would suspect that others on this line would also.
If not, my email address is here also, and I'm more than happy to respond via email as well. Touch on play therapy in younger children. Yes, so I have minimal training in that from graduate school. There's some evidence to support that, and it's a bit more like unstructured and it follows the child. So for some very young children, they find benefit from play therapy. At this point in time, the strongest evidence, even in children as young as 3, is TFCBT, however. And so if we're thinking about like addressing the trauma and kind of doing more skills-based work, that's the current status of the literature. But there is evidence for some play therapy, yes.
While we're waiting for other questions, I will go ahead and touch a little bit on some of the things that Dr. Ross Young mentioned about CPAN. If you are a Texas primary care provider and you are working with patients under age 23, we at Texas CPAN are available to support you in the mental health care of your patients. You can contact us, talk to a child psychiatrist in less than 30 minutes. I think last month it was less than 5 minutes for me to get one of our child psychiatrists on the phone with our staff. And we will address your concerns or questions. Also, if your patient, if you feel like your patient needs to see a child psychiatrist for a full evaluation, we can provide a one-time full diagnostic psychiatric evaluation for your pediatric patient under age 23 at no cost through Texas CPAN. To initiate that, you contact your local CPAN, speak with one of the child psychiatrists and let them know what's going on and why you feel like that psychiatry consult would be beneficial. And I'll tell you what we've been able to do is get them in less than 2 weeks. The biggest challenge is obviously getting the parents to complete the paperwork, but that's done virtually, and so the family doesn't have to travel. And our team here is, as well as the team at UTMB, it would be more than happy to help you with that. Just contact us at our number, either through calling our number or the text line. If you are not enrolled in CPAN and you would like to be enrolled in CPAN, which we encourage all primary care providers in Texas to do, you can contact that link at the that I've put in the chat, rcpaninfo@uttyler.edu. Additionally, Dr. Ross Young mentioned the assistance in finding referrals and resources. What I have found in working with clinics, especially large clinic groups, is that if you're requesting assistance for counseling and you send that through your referral department, those referral folks aren't trained in mental health. So they can certainly get you some names of providers to provide some counseling or some testing, but they're not going to have the skill of knowing what kind of counseling and testing is needed. Our teams at Texas CPAN are mental health specialists and can help get that information, vet it, and get it back to you in less than 24 hours. Yes, no kidding. Less than 24 hours, you can have vetted resources back to you that you can then provide to your families. I'm going to pause and open up for questions again. They're all virtual. They are held by our faculty here that work with Texas CPAN. So those are all virtual. And even if the child is very young, it's okay, because a lot of what is done between the psychiatrist and the patient is including, of course, that patient's parents. So yes, those are conversations I've had with our psychiatrists. They are all virtual. Great question, Dr. Carver. We would love to help you with that. More questions? You have an expert on the phone here with Dr. Ross Young. Let's see if we can stump her. I've never been able to stump her. She's pretty awesome. Okay, I'm going to mention our continuing education real quick. We do have continuing education every single month through Texas CPAN. Next month is going to be clinical pearls, trauma assessment and diagnosis, and pediatric primary care. You may be getting to see what the theme of the next few months is. We are trauma focused. And the reason for that is we here in Northeast Texas we have a lot of trauma, and what we're finding is that it's not getting screened and it's not getting treated. So we would love to be able to support you with that. That will be on the 25th of February. Then Project Echo starts on the 6th of February as well. We have 5 sessions, all focused on pediatric mental health. Those will be held at the statewide level. We're excited about that. For more information, you can contact us at Texas CPAN here at cpaninfo@uttyler.edu, and we can get you the information on Project Echo. If you've never done that, I encourage you to do that. That is about 15 minutes of didactic and 45 minutes of case discussion. And if you are a primary care provider, you are going to learn a lot. It is excellent, excellent conversations. All right, we have a couple of minutes left. Let's see if we can stump Dr. Ross Young.
If I may, Laura, I do also just want to plug Project Echo because I was able to attend some of them last year and they were wonderful presentations. So
yeah, those are all facilitated by CPAN faculty. They're faculty at all the universities. And so each of the universities across Texas, all 12 of them, will be facilitating over the spring and the fall sessions. So contact us. We would love to have you join. Free education and knowledge in the area of pediatric and adolescent mental health. Dr. Ross Young, I think you just educated them to the end. There are no questions here. So we'll go ahead and close today. Anything else you want to add, Dr. Ross Young?
I think we had a question I heard somebody say something.
It's me, Laura. This is Dawn Johnson from Tyler. I just wanted to know, what is the youngest patient you've actually diagnosed with schizophrenia? I used to be an child and adolescent psych nurse, and during my time of inpatient, everyone was super, super, super hesitant. Even though I felt like it was the real deal. But what is the youngest that you have felt comfortable? What is the youngest patient assigning that diagnosis?
That's a great question. The youngest one that I've personally seen was 15, and there were a couple of extenuating circumstances in terms of this was a patient with juvenile justice involvement who did have a history of substance use, but was no longer in the acute intoxication or withdrawal phase. And so it really seemed like that substance use had impacted that genetic predisposition and kind of triggered, unfortunately, a more long-lasting illness. So I would say that's about the youngest I've seen in terms of where I felt really comfortable saying, yes, this is not due to something else that we can treat more acutely.
Thank you.
Good question. Yeah, no, great question.
Any other questions today?
My email's available. I'm happy for folks to reach out if they think of something afterwards.
All right. Thank you, Dr. Ross Young, again. Thank you all for joining us today. We'll go ahead and close up our session today. We hope to see you next month, either at Project Echo or at our session on our Clinical Pearl session. Have a fantastic Tuesday and the rest of your week. Bye now.
Bye, everyone.